This has been sort of a highly requested topic. And it was really wonderful that our fabulous second year fellow, Jocelyn Keehner, when I asked if she would be willing to talk about COVID-19 and pregnancy, said, absolutely, sign me up. Maybe she was scared I might do something. No, I'm just kidding. But she jumped at this and has been involved in a lot of the COVID-19 efforts. So it seemed like it was potentially a good fit. And I know this is a topic a lot of people have questions around. I'm not sure we have a lot of answers quite yet. But I do want to introduce Dr. Keehner. She is as I said, a second year infectious diseases fellow. And most of her research this year focuses on infection prevention and hospital epidemiology. But she's also part of the antimicrobial stewardship team. She's also working on a project with Dr. Barty around mood disorders following COVID-19 recovery. And she's also one of our Owen Clinic fellows. So she works with us over there as well. As usual, you can chat me privately or put a question into the chat. I will only ask Dr. Keehner clarifying questions. We'll try to save discussion and questions for the end. And with that, I will pass it along to Jocelyn.
Awesome. Thank you so much. Caveat, I'm an ID fellow, so I am not an obstetrician at all. So a lot of, I had to relearn a lot of physiology in anticipation of this. So if I'm wrong and anyone knows better, please feel free to interrupt me. So I wanted to, disclosures, I have nothing to disclose. I don't have any investments or anything like that. I unfortunately. So I wanted to talk a little bit about like the physiology of pregnancy, why, like what is so different about it, why we get concerned, what are the features of it that could potentially make a COVID infection worse. I want to talk about COVID specifically in pregnancy. What are the complications for the mother? So like, what's the mortality rate like? Are they more likely to get severe illness? But then also, what are the complications for the fetus? Do they have more negative outcomes? And then, one of the questions that always comes up is transmission, crossing the placenta. Is that a thing that seems to be happening in COVID-19? And then we'll talk a little bit about treatments. And treatments is where I've kind of been I was covering the remdesivir page for about 7 months. And so occasionally we get calls about pregnant patients. And so we can talk a little bit about some of the approved treatments for COVID-19 and pregnancy. So the physiology of pregnancy, to take you back, those of us who are internal medicine or ID trained. Some of the physiologic changes of pregnancy. So it is, you have to grow an entire organism. So there's a lot of things that have to kind of shift, upregulation of certain things. There's an increase in plasma volume by about 50%, which accounts for the drop in hemoglobin that people notice. And so it's more kind of a more plasma volume than really like a lower hemoglobin. The cardiac output increases pretty dramatically by 30 to 50%, which is one of those reasons why it's pregnancy can be a dangerous state, especially for people with underlying heart problems, heart failure, stuff like that, pulmonary hypertension, things like that. Platelet count falls progressively over the course of pregnancy, but it's usually kind of above 100. And so you don't really run into a huge amount of the bleeding issues associated with it. There are increased iron, folate, and B12 requirements, again, like trying to create another human being. There's a lot of need to do that. I think a lot of people know about this. Pregnant women become hypercoagulable, right? This is one of the risk factors for VTE and PE. Notably, there is an increased factor 8, factor 9, and factor 10, along with increased fibrinogen, specifically by up to about 50%. And the fibrinolytic activity is decreased. Concentrations of antithrombin 3 and protein S decrease as well. And what I thought was interesting was the hypercoagulability kind of can be persistent up to 12 weeks after delivery. And again, that makes sense, right? You're about to have a major event where you have this like organ, the placenta, that is like highly perfused, and all of a sudden you need it to stop being, right? You need to be able to pass it without having a major bleed. And so I think kind of everything is intended towards that goal. You can also get venous stasis, due to the pressure of the uterus on physical structures. You can have compression of the left iliac vein by the left iliac artery and the ovarian artery, which again, anytime you get stasis and lack of flow, you can have especially in this hypercoagulable state, you can have DVT. You also get the maternal hyperventilation. It's like kind of just an adjustment of the set point. There is increased oxygen demand because you have an entire, there's increased metabolic rate that's associated with it too. And then maternal insulin resistance. So it's kind of a lot of changes that are happening all at once. Progressively over the course of 9 months. But it's a shift, and as you might imagine, some of these could have potential implications for infection with COVID-19. So, renal impacts of pregnancy. This I thought was interesting because I didn't know this. Apparently, there's a pretty significant activation of the renin-angiotensin system, kind of in response to systemic vasodilation that happens as a result of pregnancy. Apparently, aldosterone can be increased pretty significantly. There's also rise in steroid hormones, cortisol, free cortisol. And then total cortisol rise, up to like 3 times like a non-pregnant level by the end of the pregnancy, which I thought was also interesting. So you can imagine, these cortisol, these steroid hormones, like what is the impact that they're having on the immune system? And so, the goal is twofold. You don't want to recognize the fetus as foreign, but you also don't want to succumb to some kind of awful infection. So it's an important balance that the pregnant body has to adjust to. In general, there's a push towards immune tolerance, which is pretty understandable. And more specifically, the immune system in pregnancy and how it impacts viral infection. There's a shift to Th2 CD4 cells from Th1. Th2 notably releases like IL-10, which can be an anti-inflammatory and kind of tends to push the adaptive immune system towards antibodies over kind of a cell-mediated immunity, which can result in like a reduced clearance of infected cells. But again, it's more like these two things have to be in balance. And so it's not like a all or one kind of a situation. There's apparently a drop in NK cells in circulation during pregnancy. There is a decrease in plasmacytoid dendritic cells, which play a role in the interferon signaling system that kind of says, hey, there's a virus here, you need to get ready, you need to up your defenses. So you could imagine that potentially could play a role in, decreased immunity during pregnancy. Apparently there's some evidence in animal models that progesterone impacts the ability to develop virus-specific antibody. Maybe that has to do with these CD4 cell shifts. And there's also some innate immune alterations as well. And so you can see that you're in a body that's now hypercoagulable. You have potentially like a decreased lung capacity over the course. It's not a total lung capacity, but people have symptoms of not being able to breathe occasionally. And then you combine that with maybe a decreased like interferon signaling and natural killer cells. And so what does that translate to specifically in COVID, because there's a massive pandemic traveling around the world? Well, so I thought this was an interesting chart. So this paper was like kind of a review paper that attempted to address this. And so it basically goes through the different viruses, overall case fatality rate and case fatality rate in pregnancy. And we can see that a lot of RNA viruses have a higher case fatality rate in pregnancy, including the initial SARS outbreak in 2000s, and then MERS, although admittedly there were, I believe, very few MERS, pregnant people who developed MERS. But you can see COVID-19, it doesn't appear to be hugely higher than, I don't think they controlled here, this is the overall case fatality rate, but, pregnancy is not a entire lifespan kind of condition. So it doesn't seem to be actually that much higher than, which you would anticipate looking at these other viruses. So what are the potential issues from like kind of pregnancy and COVID, specifically the things that you think about? So gravid uterus impacts lung capacity, not hugely. We can see it more so, you have this tidal volume increase as a result of this hyperventilation. And so maybe some of the inspiratory reserve capacity goes down, and that could be related to it. I do know, I read when I was reading about this, apparently like some people have issues clearing secretions, and so are more predisposed to kind of developing illness in that context. COVID is associated with thrombotic events, as is pregnancy. In fact, the guidelines I read several places for pregnant patients is to start them on thromboprophylaxis while like acutely ill from COVID. I believe it's low molecular weight heparin, and then kind of continue it for a few days after. I think about like 10 days until there's a recovery. And where does what are the potential issues associated with COVID? We have these hypercoagulation. So PE, DVT, PE, stroke. There was like a couple reports earlier of like myocarditis of COVID, but it's not clear if that's like a thing or not. But again, pregnancy is a high cardiac output state. It's a high kind of a strain state that gets placed on your heart and your cardiovascular system. And there's vasodilation of pregnancy, and there's also concerns, when you have blood clots to the lungs from the legs, there's concerns about placenta, like the ability to perfuse the placenta as well. Because if you can imagine, you get clots there, you can get clots there as well. If you can get clots in those systems. And so I just wanted to explore a little bit about what it actually looks like. So these are all these theoretical potential complications, but what does it look like in a real world scenario? What are the rates of these different complications? So I'm going to present like a series of reports. This is 24 studies in this review. It came out a few months ago. 324 pregnant women in total, and there were 8 consecutive case series, and then one was a case series specifically looking at severe COVID. So it's again, it's not random, or at least that one wasn't random. And then 15 case reports, and so they looked over and they looked basically. Overall, maternal age range was 20 to 44. Gestational age kind of spanned the entirety of pregnancy. The most common symptoms were fever, cough, fatigue, myalgia, dyspnea, which is what one would anticipate. Throughout the case series that they had, the rate of severe pneumonia ranged from 0% to 14%. It's a pretty broad range. Again, one of these case series was in severe COVID. There were only 4 cases of spontaneous miscarriage or termination. APGAR scores were pretty good, and then however, 1/3 of newborns were transferred to the NICU. So neonates, when they were born, ended up in the NICU. Only 3 out of 155, though, tested positive for SARS-CoV-2 via throat swab prior to discharge from the hospital. So, the concern for vertical transmission seems to be, not as, it can happen, but it's not as common. And then as far as mortality, so in the 8 consecutive case series, there was no mortality, but when they looked at the severe COVID, there were 7 deaths and 4 intrauterine fetal deaths. Within the 15 case reports, there were 2 maternal deaths and 1 newborn death. But again, this is not a random sampling. This is just a review of case reports. So then they went and looked at, I believe this is an Italian hospital, where they had 42 women with COVID-19 who were pregnant. 30 had term deliveries, spontaneous preterm birth in 5, and C-section in 6, 24 delivered vaginally. In general, an elective cesarean section was performed there were 24 who were vaginally, and then the others had an elective cesarean section. 8 of those cases, the decision for C-section was felt to not be related to COVID. Pneumonia was diagnosed in about half of the mothers, with 7 out of 42 of them needing supplemental oxygen, and 4 out of 42 were admitted to intensive care unit. 2 of them initially breastfed without a mask because they were diagnosed postpartum with SARS, and then their newborns were subsequently tested positive. In total of the 42 women, there were only 3 positive among the newborns. The other was positive after a vaginal operative delivery. So kind of pointing towards the idea that maybe there's not a huge amount of vertical transmission, but we'll get into the serology because the serology maybe shows a little bit more information. But again, not a lot. It's not a lot.
Jocelyn, I'm going to ask a question because I had the same one that Gigi had on the
Yeah,
slide before,
sure.
which was why did they think so many infants needed to go to the NICU? Was it, out of an abundance of caution and people not knowing anything? I seem to recall that was happening at least in our hospital at the beginning, but I don't know if they got into that because it does seem like, quite a few, obviously.
I'm not sure, but I can get back to you. I can like trace down some of the case stuff, like specifically from the case reports if you'd like, and get back about it. Because it is, I agree with you, it's a really high percentage. Like, why would that be? Especially if a lot of people were at term.
Right.
Theoretically, that shouldn't happen.
And I, yeah, and it's just curious if they would do throat swabs. I just don't know if that is the correct place to swab for a neonate. But anyway, and then for this,
it was like a mouth swab. It was.
I guess else to swab.
You mean as opposed to like a nasal swab, Gigi, or
No. I'm just thinking it would be a hematogenously spread infection, right? It would go via the umbilical cord. But maybe we just don't have, we're still learning, so we don't know the right.
I do have some more information on that. When they look for PCR in blood isn't really helpful, but antibodies is what they kind of use to see if people are infected.
Right, which isn't helpful in neonates because you're going to get moms.
IgM doesn't cross the placental barrier, so
okay.
And you'll get to all of this, right, Jocelyn? Sorry.
I know.
Sorry. This was important. No, thanks, Gigi, for bringing that up. We'll let you keep going. Thanks, Jocelyn.
Yeah, no problem. So where were we? Okay, so this was interesting. This was just published. This was like at the Society for Maternal Fetal Medicine. It was a poster on the 28th. I found it online, found the abstract online. So they had about 1,200 pregnant patients diagnosed with COVID-19. About half were asymptomatic, and then mild to moderate, severe, and critical from there. So again, it's just respective of the broader risk factors for COVID-19, right? Age, BMI, medical comorbidities associated with more severe disease. Not totally surprising. Cough, dyspnea, myalgias, about what you would expect. 4 deaths were attributed to COVID in this cohort, so about 0.3%. So, comparable with kind of a similar percentage for the same age group. Not crazy high like we would see in SARS or MERS, SARS-1 or MERS is kind of the end point of this. The more critical the illness, the higher bad perinatal outcomes. And then overall, there was about a 6% VTE rate with severe critical disease, which is, again, not hugely surprising when you think about, the clotting associated with COVID-19 and then the hypercoagulability of pregnancy. And then they did note in this particular study, severe critical COVID-19 was associated with, need for C-section, postpartum hemorrhage, hypertension of pregnancy and preterm birth compared with asymptomatic patients, which is now, I guess, not something that is super surprising. In this particular cohort, only about 1% of newborns tested positive for SARS-CoV-2, and I can go back and see what they did, like how they tested. So this is one of the larger studies. This is actually going to be helpful, and they were able to actually compare this pregnant population to an unpregnant and non-pregnant cohort to give you really good rates. So basically, CDC identified 8,000, and so there were more pregnant people, but these were like they identified 8,000 pregnant patients. They were able to obtain health information on between January and June. Pregnant and non-pregnant cohorts, and these are pregnant patients with COVID-19. Pregnant and non-pregnant cohorts reported similar frequencies of cough and shortness of breath. The pregnant women had fewer headaches, myalgias, whatever that's worth. Now, they noted that 31% of pregnant women with COVID-19 were hospitalized compared with 5.8% of non-pregnant women. Now, is that because they were sicker, or is that more because an abundance of caution? These are important questions. They did note that after adjusting for age, presence of underlying medical comorbidities, which are this is the concern, and race ethnicity, pregnant women were significantly more likely to be admitted to the intensive care unit and receive mechanical ventilation. There were 16 COVID-19 related deaths among pregnant and 208 among non-pregnant during this time frame in this particular these two cohorts. Notably, it's the same mortality rate regardless. So kind of it seems that mortality is similar with pregnant versus non-pregnant women. However, pregnant women are more likely to require ICU stays and intubations if we're trying to learn from this morbidity mortality report, which is reassuring that, the mortality rate doesn't appear to be, what one would anticipate based on other viruses, other viral infections. And okay, so this kind of followed this cohort study of 3,000 pregnant women. So basically identified this cohort. They tested everyone. They identified 252 who tested positive for SARS-CoV-2 during pregnancy. And you can see there were similar rates of aborted fetuses, spontaneous abortions. 97% on both groups had delivered pregnancies. And there were only 2% malformations in each. So kind of comparable rates of malformation. The primary outcome in this, so, we were looking previously at like maternal mortality and severe illness requiring intubation, requiring ICU stay, which appears to be a little bit higher in the COVID group. Here, looking at outcomes for babies. There was no significant difference in primary outcomes. So no significant difference in preterm birth, preeclampsia with severe features, and cesarean delivery, like necessitation of cesarean delivery for fetal indication between these two groups. What I thought was interesting was this was a study in Texas, and they were able to have a pretty high rate of people, and like Hispanic people, Black people are much higher rates of COVID in the community compared to, and so this is representative of, maybe overrepresentative of the people who do end up getting COVID. So that's what I thought was great to look at, and seem to get more severe COVID when they get COVID and have higher mortality rates in general. What I thought was interesting was that neonatal COVID occurred in about 3%. And most of the mothers that it occurred in were asymptomatic or polysymptomatic, which then makes you think, well, okay, which, kind of is our understanding of people with asymptomatic or polysymptomatic COVID can lose their humoral immunity kind of quicker than potentially than people who are more severe disease. And so is it, the babies with moms who have like a robust symptomatic and a robust immune response are kind of like, they're getting their own version of convalescent plasma, right? And so maybe they're not going to get it as much because they're kind of swimming in that antibody. Anyway, that was just a thought I had. So this is from that study, and you can see primary outcomes, the rates are not statistically significantly different. The risk ratio is not, and in fact, it's lower compared to the COVID negative cohort. And a lot of the outcomes are not significantly different in either one, which was, I thought, pretty interesting. Excessive blood loss, all pretty comparable. And Brazil, however, it's a different scenario. So, reading through this and trying to identify, around the world, mortality rate. So there were in this population of, I believe it was 978, so almost 1,000 pregnant women with COVID. The mortality rate was like 12.7%. You're saying that's a lot higher than our mortality rate, and why is it so bad? A big part of it is there's like not, at least at the time of this publication, there was not like almost no asymptomatic or polysymptomatic testing. So only women who ended up pretty sick with it ended up getting tested. And apparently there was also an issue with ICU availability. And if we look back at a previous study that showed basically that they do have higher rates of ICU admission. Now, whether that's an abundance of caution or not, but they do have higher rates of intubation. And so is like a ability to be close to an ICU kind of the distinguishing factor that separates, the mortality rate. It explains why the mortality rate is not super high in the US compared to. But I think a lot of this is testing. A lot of this is like a testing issue there because they're not testing people with kind of minimal to no symptoms. And so then I want to talk about vertical transmission. Gigi had mentioned, so we'll talk a little bit about that. There's some data, and this one paper was really interesting. I like the graph, and so I'm gonna show you the image. I'm sorry from it, which I really enjoyed. So basically, 13 pregnant women, and they kind of sampled everywhere. So 5 gave birth during the study, 2 were premature, and 2 had neonatal pneumonia. From mom, 1 out of 9 moms had a positive PCR stool sample, but again, they all had COVID. The vaginal samples from mom were negative. Throat swabs and anal swabs were negative from the babies. What was interesting was 1 of the 3 breast milk samples was positive. However, there's a bunch of antibodies in it, then you're maybe less concerned. So this was the graph from the paper. What I thought was interesting about this was, so there were of the 5 babies, 2 had diagnosed pneumonia. However, 1 had suspected pneumonia, and then 1 had increased lung markings. And so then it's like, well, then is it more than 2? But it's hard to say with certainty in such a small sample size that it means anything significant. But again, this study looked at PCR testing, which may not be the most helpful in diagnosis. If you think, in that one study where there were 3 and 2 of them happened when mom breastfed without a face mask, then you would think, well, maybe the nasopharyngeal is not a bad place to look if we don't think it's a lot of placental transfer, if we think a lot of it is from, just being around mom, then that would make sense. So this I thought was interesting. It looked basically at the antibodies. It only looked at 6 mothers, but to go back to what you were saying. So IgG is elevated in all 6 infants, travels across the placenta. That's not a huge shock. However, IgM was elevated in 2. Typically, it's too large to cross the placenta. Now, could this be in the setting of maybe there was some placental damage, and so which disrupted the typical, or the alternate would be that there's vertical transmission of virus resulting in IgM production by the newborn, which is a thing. It's kind of the only antibody. It's one of the few antibodies they make. But that's kind of the question. Then this study is one that's commonly referred to when they're raising questions about vertical transmission. So the placenta, just briefly, we know viruses can cross the placenta. It's a huge problem, and it's one of the congenital malformations, HSV, zoster, CMV, and Zika. Again, negative consequences for the fetus, but not all viruses cross the placenta. There are case reports, where they have detected SARS-CoV-2 in the placenta and amniotic fluid, but less often are they able to find it in the actual fetal tissues. However, thrombosis can cause issues with placental perfusion, which could potentially disrupt this barrier. And then in a case series they examined, and I was interested to see what are the impacts of COVID on the placenta, primarily because it's a vascular organ, and we know that there's coagulation issues in pregnancy and COVID. And they looked at 15 placentas of COVID positive mothers, and they compared them to controls. And it was interesting, the controls that they selected were pregnant patients with a history of melanoma, because apparently they have similar kind of clotting risk. But I think part of it was also that they look for melanoma in the placenta. But the COVID positive placentas were significantly more likely to have evidence of maternal vascular malperfusion compared to matched controls. Kind of 12 out of 15 of them did. And this is just the pathological diagnoses that they had. There's infarction, which is probably going to cause leakage of different things around it. They had agglutination, some necrosis. There was a couple hematomas, you can see. So, there is some evidence that COVID potentially, and it seems like there's not a lot of negative outcomes associated with it, but it seems that it could potentially causes maybe some minor complications, which have long-term downstream implications. So let's go back. So yeah, we can see that COVID doesn't seem to, in places where you have readily access to a ventilator, doesn't seem to have too many negative consequences for, the mortality rate's not significantly higher in pregnant populations. the rate of preterm delivery, cesarean, et cetera, doesn't seem to be any like higher, significantly higher in COVID compared to non-COVID controls. And so, perhaps the fear that we had of infected pregnant women is not as it doesn't seem to be panning out as significantly. However, there are higher rates of severe illness with ICU admission. There are higher rates of intubation. So it is bad. It's just the mortality rate seems to be pretty comparable to the age matched controls. And so it seems to be not statistically significantly different from, especially for the preterm birth kind of endpoint. So what can we do? How can we treat people? So this is kind of the overall, which we see a lot, is they basically recommend that you not withhold a potentially life-saving treatment because of theoretical concerns, which is I feel like something that we go back to all the time is it's the risk-benefit conversation, right? So none of these studies included pregnant people because of the risks associated with potentially exposing the fetus to teratogens, all kinds of things. But the biggest risk for the baby would be if the mother died, right? So it's always this risk-benefit conversation you have to have. So as far as and so big pictures, you only kind of want to give people the treatments we actually know work. You wouldn't want to give someone hydroxychloroquine, right? So you kind of want to look at the data. We have been giving remdesivir to pregnant patients as part of the remdesivir pager. And the data for that, it's not a lot, but I imagine we'll be able to have some coming out of this. But prior to COVID, they've given it, I think there were like 6 cases of pregnant women with Ebola who got remdesivir, but they kind of weren't well described. It is, the viral RNA polymerase inhibitor, and so maybe it's not going to have theoretically a huge risk to the developing fetus because it's, specific for this RNA polymerase, and that maybe that's why we're not as concerned. I do know that one of the corticosteroid arms, the recovery trial, they did include in it prednisolone hydrocortisone as an alternate to dexamethasone, which crosses the placenta. And so they were planning out for it, but I don't believe they published any data on pregnant women with this. But again, we give steroids to pregnant women all the time to help lung maturation. And so this is one of the things they say it's okay. But again, all of these are like kind of a risk-benefit discussion, right? And it's all this for any of the experimental treatments without clear contraindications, shared decision-making. And then it's hard to know whether or not to include them since most trials don't include pregnant or lactating women. And this is what happens. It's like hard to say with any certainty because they don't study pregnant women, because you can't study pregnant women because what if something's really bad? And so kind of all you can go off of, and this is accidental administration. So for tocilizumab, I thought this was interesting. So there was a 35-year-old woman at 22 weeks who got successfully treated with tocilizumab and remdesivir. I don't think she had delivered at the time of this case report. But in a database review from 2016, they identified 288 people who were pregnant and had been exposed to tocilizumab either right before they got pregnant or during their pregnancy, kind of accidentally. They did note an increased rate of preterm birth. The risk of malformation didn't appear to be substantially elevated, maybe a little bit, but not substantially. So kind of all you can go on is kind of this, again, because it's hard to do an actual trial in pregnant patients. And then I thought initially I hadn't addressed the outpatient, but it's the same thing, should not be withheld if people have a high risk of progression. Kind of the idea behind it is that if mom dies, that is the worst outcome for the baby, right? Especially if they're not near to term at all. And it's the same thing for the dual antibody. And so, which isn't a lot of guidance and is I would imagine is really hard for clinicians. So I do believe that obstetricians are constantly making these decisions, right? And so I think it's something that they're very familiar with in this kind of decision structure is risk benefit. So in conclusion, vertical transmission, there's some evidence like the IgM positivity in the babies and then some of the PCRs being positive after birth. There's a mixed reports of positivity in breast milk However, in general, recommendations are to continue breastfeeding when the mother is COVID positive. However, they do recommend that mothers wear like hospital grade or medical grade face masks while breastfeeding and practice good hygiene, because it does appear that is a transmission avenue. Although, you know, the mortality rates in babies with COVID is pretty low. Not zero, obviously not zero, but pretty low. And so people are less concerned about, you know, infants being infected. It seems that mortality rates are similar between pregnant and non-pregnant women of similar age and comorbidity. However, pregnant women appear more likely to require ICU stay and ventilation, so they can get more severe illness. But if they have access to those facilities, those resources, the mortality rates appear similar. Again, in resource limited settings, could be impact mortality rates. It could be a bigger issue. The question of how to treat, it's a big question. You know, what do we do? Consistently, the recommendations favor improving the mortality rate in the mother when illness is severe, and you know, in the absence of like an absolute, like a known teratogen, like a known problematic medication. In general, they favor, if there's good evidence that it improves outcomes and there's like a high risk for progression to severe disease, then it would probably favor treatment. And a lot of those, in that one case series, the cohort study, they gave tocilizumab to pregnant patients. They gave dexamethasone even though across the placental barriers. So people are receiving these medications because the goal is to save their lives, and understandably that is a big important thing. So happy to talk about any questions or anything like that. Discussion, if anyone has anything that they want to say.
Thanks, Jocelyn. Yes, so I think Larry asked a question and is a little bit out of the scope, but you know, of what you've talked about. But he's asking, and this doesn't necessarily have to be to you, it could be to anyone, what is the current recommendation for vaccination during pregnancy?
Yeah, I was wondering if that, I was thought about including it.
Yeah, no, I mean, I think this is, and we could have a whole discussion about this. I don't know how well versed you are on this and what the recommendation.
Only because I have 2 friends who are pregnant right now. Yeah. So I think, I mean, they recommend, I know people, I think they recommend getting it. Is my understanding.
Yeah, it's definitely recommended. I don't know what the level of, you know, what the level of evidence is. There's no evidence, I mean, so I don't know if it's a B or a C. Right. And I don't know if anyone can speak to that. I know that all the societies have come out and you know, recommended women getting vaccinations. I was hoping that Susan Little was on the call. Doesn't look like she is, but I see Kathy Primrose. And just for those of us who've been involved in the vaccine trials, I think what was really hard, and this is to your point of, you know, how can you not include women and make recommendations, but how can you include them not knowing if it's safe? So you know, all of the vaccine studies very vehemently denied women who were pregnant or could potentially become pregnant in the studies, which makes it so that we really don't have much evidence on whether, you know, it's safe, but I think more importantly, if it works.
Right. I just looked up quickly. Apparently, so the CDC, and this is a Harvard blog post, Harvard Medical School blog post from the 28th of January. CDC, ACOG, and the Society for Maternal Fetal Medicine agree that the vaccine should be offered to pregnant and breastfeeding patients who are eligible. However, apparently the World Health Organization recommends against using mRNA vaccines, but I have to look into why specifically they recommend against it. But everyone here in the US recommends it. But again, this is like a new vaccine technology, right? It's not like a known like thing that has been in use for a long time, you know, the mRNA vaccines.
I do know that there were some people that got pregnant. I don't have the data, and I think this is more just like internal discussions. I was discussing this with Steve Spector, who I don't think is also on the call. I know that there were people who did get pregnant after they got their vaccines in study. And I just don't think we have enough information about them yet. I think more of this will come out, obviously, but I think it was very, to me, it was somewhat distressing to go through the study. And then as soon as it was done, say to pregnant women, yeah, no, you should definitely get the vaccine when they weren't included in the study. And I think if you're doing an informed consent process, that's how studies work, and people can choose if they want to participate in the studies, but we're left with this gaping hole. But I'd be curious if other people have thoughts.
Hi, this is Gigi. Jocelyn, I thought that was an outstanding presentation. Thank you. One of my thoughts just as you were presenting was that it seems very reassuring that there's not this dramatically increased risk to the mothers outside of their, the usual risk factors. But it does seem like there are more complications to the infants. And one of my other thoughts. So I wonder if we're going to not know the answer to these questions until these infants have a chance to grow up and see, do they have any learning disabilities, and, are there other issues? So I would assume there's a registry I hope there's a registry for
I think there are.
these.
I think there are multiple registries.
Yeah. Great. No, there should be. There really should be. And then for just my other curiosity is for all those women who do end up in the ICU intubated and on all those drugs, what are the outcomes? What does that mean to a growing fetus in their brain?
And it's hard to know now, right? Because it's not
exactly.
It's not 3 years maybe that will really get a understanding of it. Yeah.
Right. So secondary problems of the COVID infection. But anyway, that was just outstanding. Thank you very much for your presentation.
I should have talked about the vaccines. I thought about it and I was like, I don't know. And then I didn't. I'm sorry.
This is a good start. We'll bring you back later. No, I'm just kidding. There's another question, and it may not be to you. It could be to anybody. Is there any data about whether there's a period of time that someone would start to wait after having the vaccine to start trying to get pregnant? Sorry. I don't think there's any data around that. Did that make sense, Jocelyn? Sorry if should people wait?
I didn't specifically look for it, and I can't unless I know, and there's like some of these reports. I know this because I have a patient with COVID who sends me all these kind of like articles. Apparently, there's a fair amount of autoimmune, like there's self-targeted antibodies. I don't know if that would play a role, but I'm not really sure. I don't think we know. I don't think so, but I don't think we know. I don't think there's, and I didn't find anything when I was looking, but if someone else wants to answer it, they should definitely. Just to answer Alan, for the placental pathology, the comparison group was pregnant women who had a previous diagnosis of melanoma or current diagnosis of melanoma was the comparison group. Anyway, sorry.
Thanks for answering that. I can only do this based on what they were recommending for the study. When we saw individuals who were of reproductive potential, I believe we were saying you can wait. And again, I don't think this is based on anything, but if someone wanted to be so careful, wait a month until after the the second vaccine was completed. I know, but this is not based on anything. It felt like there was a lot of sort of making things up, as we went along. I don't know if other people have thoughts about that. I mean, obviously, if they're recommending that pregnant people get it, there shouldn't be a reason why you have to wait. But yeah.
I mean, with Janssen and AZ, I think we said 3 months.
How many months?
3.
3 months after the second vaccine.
Yeah. Well, for Janssen, it's
Janssen, right?
Only one,
just one shot, right?
Yeah. So I guess if you wanted to be a purist, I mean, if people are saying, "Oh, what was studied," I guess they could wait to start trying until 3 months after.
I just don't know what it's based on at all, and I don't know what that 3 month period is supposed to do. I'd love if someone had thoughts about it. Do you see this next question? I think there's a lot of vaccine questions.
I didn't think about vaccines. I should have. I don't know.
Yeah, I would throw this out to the group and see if anyone has attention to this. No, Scott, it's a great question because I think it's important, and I don't know if anyone has any thoughts about whether the lipid nanoparticle vaccines would differently affect children than the adenovirus vaccines. I'm assuming you mean, fetuses as opposed to young children who might get the vaccine. Yeah. I wouldn't even begin to.
Apparently, I don't know how to unmute myself today.
I mean, do you have any thoughts about this? I know.
I don't. I think from I was thinking about the IBC review of the adenovirus vaccines, in which they are, they're attenuated and they're supposedly replication incompetent, but I think that there is evidence of very limited replication, like one cycle in vitro, and so the HGT IBC, was brought that up as just an issue to pay attention to. I still think they're entirely safe, except for those people who have a reaction to them. But I hadn't really thought much about, giving them to pregnant women. There is this issue, which I guess shouldn't affect fetuses, but could affect mothers. But there was this letter written to the Lancet from the people who ran the adenovirus HIV vaccine trials about the issue they saw in those trials, in which some people had an increased risk of acquiring HIV. And it turned out to be uncircumcised men who practice insertive sex. And they did additional work. My initial thought when I read that was, well, that's got to do with HIV, but they did additional work to understand whether that was, artifactual or biological. I guess I can turn on my video as well. And it seemed to be biological. What they found was that in men who had an adenovirus infection before, when they received the adenovirus HIV vaccine, they had a greater increase in immune activation. And when you have an increase in immune activation, you get, activated cells go where they normally go, and the penile foreskin is very rich in CD4 positive T cells. And so it's a stretch to say, okay, well, and that then increased the risk of them getting HIV because they had more target cells there. So that's a stretch, but it is to say that if a mother, something we're not tracking, but if a mother had a prior adenovirus infection, and many mothers will have had one, and then we give them an adenovirus vaccine and they get more immune activation than someone who has had only a distant or not an adenovirus prior adenovirus infection, are there different effects on the fetus then from an adenovirus vaccine compared with the lipid nanoparticle vaccine? So anyway, I mean, as you said, there's a lot of unanswered questions. I think Gigi's points about and yours, Jocelyn, about tracking people are very, very important questions to address.
I'm muted. There's another question about vaccines. Don't hide yourself, Scott, because you I feel like are the lipid nanoparticle expert. Just someone's asking. I wouldn't know how to touch this one. Are there any issues with pregnant women who have antiphospholipid antibodies getting a messenger RNA vaccine?
I am not the lipid nanoparticle.
I'm making you that. That's.
I know. I'd turf it to one of our vaccine experts, like Dr. Oxman or someone. So, but yeah, I don't know anything about that myself.
Yeah, I know Dr. Oxman was on. I don't know if you would like to try to take that question? Mike, I see that you're muted. Maybe you're taking a break doing something else. Oh.
I think that repeat the question quickly.
The question was, would there be any issue with pregnant women who have antiphospholipid syndrome getting a messenger RNA vaccine with respect to the lipid nanoparticle?
I don't see a reason why, although I'm not very up on that syndrome. I think I was just in the process of writing a note saying that I think that the Pfizer or Moderna mRNA vaccines should not pose any risk for pregnant women or the fetus. And my assessment of the risk-benefit ratio leads me to recommend vaccination with either of those vaccines at the earliest possible point in pregnancy. I don't feel that way at all about adenovirus vaccines. I think they have a lot of potential risks for pregnant women over and above those for ordinary people.
Thanks so much, Mike. I hope I didn't miss any of the other questions that came through here. I think, and a lot of, great presentations that you can see, I'm sure, Jocelyn, since this is really, important. At some point, and I don't mean to open this up now, I think a lot of us in the HIV world, want to know if there's any increased risk. And I don't know if there's enough data quite yet to women living with HIV in pregnancy with COVID. And I don't know if you came across anything, and if not, no worries, we'll just have you back. No, and I don't know if anyone else has any information around that. Okay. That's fine too. These will, we will keep we'll keep coming back to these things. So, all right. Well, thanks. Sorry, what, Jocelyn?
No, there's some paper. I have found some papers, but I can share them with people. I can send an email if people are interested.
Okay.
Yeah.
Thanks so much. All right. So many thank yous. I think a lot of people with people in their families and friends who've gotten pregnant, this is perhaps reassuring data in a lot of ways, and it's good to hear where we are. Obviously, we still have a lot to learn, and we'll just keep going with things. Collect that data, get people enrolled in studies so we can learn more. I think next week we have one of our ID Global Public Health colleagues, who's now in the School of Public Health. I think that's what it's called, the new Herbert School of Public Health and Longevity. I'm sorry, I'm butchering that. But to give a presentation will be Heather Pines, I believe. So we will see you all next week. Please fill out the evaluation if you can, helps us improve things going forward. I haven't said this in a while. If there are topics that you're really interested in hearing about, you can certainly send an email to myself and Marvin, and we can see what we can do. We're just sort of rolling, but we're always looking for ideas and specific things that people would like to hear about. One thing that did come up recently is, there's a lot about the long-acting injectables that are now FDA approved and will be rolling out. We will have Miley Karis Young give a call, talk about this in April. I think this has been a very important and hot topic recently, so stay tuned for that. All right, bye everyone, have a good day.